I'm going to talk about some of the issues in medical oncology. I think it's vital, as we've seen, that we be incredibly brief. So I'm going to talk about some of the things that are concerning us from a medical oncology perspective. And we've had huge changes in medical oncology for colorectal cancer since I started as a consultant 20 years ago. I've put up our current usual treatment program for locally advanced neoadjuvant chemotherapy. We're using capecitabine now instead of infusional 5-FU. It's easier. Andrew tells all the patients they're going to have it before we get to see them, so we're stuck. It's now become generic and has gone from $750 a throw to $75 a throw, so it's very cheap. Then they have surgery afterwards. Then we review the path and we determine what adjuvant therapy to use. We've been using capecitabine to continue the therapy they've had. We haven't had lines. The more recent evidence suggests is we may have been doing the wrong thing and they might need their chemo revved up. So I'm just going to go through and give an overview. I'm not going to go through all the medical oncology studies, but these are some of the things that we've looked at. What combines best in terms of chemotherapy with radiotherapy? Do you need adjuvant chemotherapy after the neoadjuvant chemoradiation? Is neoadjuvant radiotherapy always necessary? What is the place of all the new targeted therapy? Are there better biomarkers? And will surgery always be necessary? Although I think Andrew's just dealt with that, so I'm not going to spend a lot of time on that. So what combines best with radiotherapy? Righto. Do new agents improve outcomes? It appears that the fluoropyrimidines are the best thing to combine with radiotherapy. We've looked at adding all the other agents, oxaliplatin, irinotecan, the targeted agents. At the moment, there's no additional benefit for those agents, and it appears the fluoropyrimidine is the best thing to combine with radiotherapy, and that's where we are at the moment. So I'm not going to show you all the trials, that's just what we're doing. Okay, so there have been some studies. There's a nice paper that addresses most of these. A number of studies have addressed the addition of oxaliplatin to various forms of infusional 5-FU, capecitabine, and the bottom line was that it doesn't seem to significantly improve complete response rate, sphincter preservation, it adds to toxicity and doesn't improve local effects. So at the moment we're not going with the additional agents. So is adjuvant chemotherapy necessary after neoadjuvant chemotherapy treatment? And if so, what's best? This is controversial and hasn't been addressed in large studies. They've had subgroup analyses of studies that have been performed. Overall, it doesn't appear that adjuvant chemotherapy benefits patients in this circumstance. On the subgroups, it looks like it's paradoxical. Those that have had the best response to the neoadjuvant treatment appear to do best with the adjuvant treatment, but that may be a self-fulfilling prophecy because they've done well with the previous treatment, they continue to do well. Our tendency is to give those who have the bad pathological elements relatively poor response, lots of nodes. We tend to give them the revved up chemo, but we may be doing it the wrong way around. But that still is our tendency, and we're not really quite sure which way to go on this. It appears also that if you add oxaliplatin to the fluoropyrimidines, as we do in colorectal cancer, that you get additional benefit as we do in colorectal cancer. So what we're probably going to be all doing now is using Folfox or Zelox in the adjuvant setting for these patients. What we don't like is for them to have had an early reversal of their ileostomy, so they've got newly joined bowel, and we're giving them chemotherapy that causes difficulty with bowel control, especially if they're celebrity patients, Professor Engel, like I saw today. Because that makes it very hard for them to handle the chemotherapy. Thank you. Is neoadjuvant radiotherapy always necessary? And I think this is going to become an interesting issue, and I think Andrew's alluded to this. There may be patients who don't need the radiotherapy, and we can probably get away with chemotherapy alone. That hasn't been studied in large randomised trials. We did some stuff at Concord where the surgeons didn't believe for a while in anything beyond TME, so we had to gradually introduce the concept of adding chemotherapy. They didn't believe in radiotherapy except for big bulky T4 lesions, and it was after a time we were actually able to show them, and they said any randomised trials didn't involve control of the surgery, which is fair enough because they didn't have respect for some surgical groups. So we were able to say after I'd been there for 15 years, what if we compare in you guys who have been here for a long time, what if we compared your results before and after the use of chemotherapy in rectal cancer to see what the benefit was. So what we did is looked at the Concord database, matched the patients up for their stage, age, all the other prognostic parameters, surgeons the same, and see what impact adjuvant chemotherapy in this group had because they weren't having radiotherapy. And surprise, surprise, we got the same survival advantage for the addition of chemotherapy compared with control in their patient group. We did the same thing with colorectal cancer for them. So before and after the introduction of chemotherapy, we achieved the same survival benefit that had been reported in all the randomised trials. So I think we do need to identify groups of patients who might not need radiotherapy that we can go with chemotherapy alone. In addition to the reduction in systemic metastases and improvement in survival, these patients also had a reduction in local recurrence. So we're probably having both a systemic effect and a local effect in this circumstance. And we may want to define groups who this fits well for in our ongoing treatment. This is a study, the Prospect study, and it's sort of along the lines of where Andrew's going, looking at neoadjuvant chemotherapy with optimal chemotherapy, looking at patients who respond well, going straight on to TME, and then maybe some adjuvant chemo. Poor response, give them chemoradiotherapy and proceed as usual. And this is the type of design I think we need to be considering in this circumstance to validate whether radiation is useful in all patients. I think the other issue that's been addressed is targeted therapies. You're probably aware in colorectal cancer now that they're showing in advanced disease patients if you can look at their total RAS status. So this is looking for mutations in a number of different genes that seem to predict for worse outcome. And there are new treatments that you're aware of that target EGFR. They're antibodies, so they're systemically administered treatment. And in advanced colorectal cancer, they've shown that if you've got no mutation, so-called wild type, and you give these patients these targeted therapies, you can get significant prolongation of survival in advanced disease. What we don't know is how this applies in this early stage disease. The studies that have been done have looked at KRAS wild type versus mutations, and they haven't shown survival advantage in that circumstance. What we don't know is what the circumstance is for the all RAS patients. And so we probably need to look at that. Avastin is hard in this circumstance because you normally need to be off Avastin for 6 weeks before surgery, and using it in this circumstance is difficult because if you're then going to go on to curative surgery, you don't want to wait too long. There have been some preliminary studies suggesting Avastin provides an improved response rate, but I don't think that's going to fly in this circumstance. But certainly cetuximab or panitumumab, if we evaluate their mutation status early, may be applicable, but this requires further studies. Are there better biomarkers? Andrew said he probably wants to fly with radiology and nuclear medicine. There probably are good biomarkers, and a number of people are looking at various tumour factors and patient factors in this circumstance to predict outcomes. You've probably seen the Oncotype DX that's being used in breast cancer, where they're looking at a whole lot of genetic markers and evaluating the whole tumour, and instead of having pathology as a diagnostic means, you're now having combinations of genes and patterns that will establish prognostic groups, and we will probably go this way in colorectal cancer. Proteomics and microRNA studies are being performed, but these are difficult and they require very complicated bioinformatic analyses, and at the moment should be regarded still as experimental. We've been looking at inflammatory markers, and these are pretty simple tests. So these are things like C-reactive protein, the ratio of the neutrophils and lymphocytes in a full blood count, and these look encouraging, and we think these should be pursued further, particularly in the chemoradiation group. In the studies that have been done, they've looked at a range of things: CRP, neutrophil lymphocyte ratio, IL-8 levels, and they've shown these to be prognostic in the group having chemoradiation and surgery. This is our patients at North Shore. These are 900 consecutive operative colorectal patients between 2005 and 2009. Subdivided on the basis of their neutrophil to lymphocyte ratio. So we think in inflammation, your neutrophils go up, your lymphocytes go down, and therefore the ratio goes up. So these are people with a low ratio, These are people with a high ratio, and this is the only difference between those patients. These are 900 consecutive patients, a fairly substantial difference in long-term survival, and we want to evaluate this further. So the surgery necessary, I think Andrew's addressed enough. So I'm going to stop there, and I think it's vital that you get on with your food and drink.